Okay, continuing on. Here are some terms that we use in PFTs, and the FEV1 is just that. It's the first second, how much you blew out of your vital capacity. So that's why I said it always starts with the vital capacity, and from there, the machine will be able to figure out these other values. So these are not separate tests per se, or these are not separate procedures. It's just get them to do the vital capacity, and then the machine will do the rest. So there could be more than just one FEV reported on the test results, because sometimes you want to know how much how much volume was exhaled in the first half second. That would be an FEV point or FEV 0.5. And 2 seconds, 3 seconds, 4 seconds, etc. And then this is where it all starts here. Okay, there we go. So this is where it all starts with the FBC. So you get them to do the deepest breath that they can, and then blast it out as hard and as fast as they can. That's the forced component. And keep encouraging them to push and push and squeeze until they can't get anything else out of their airways, and then that'll be the FBC. Now, this normally takes about 6 seconds, and that's kind of the guideline that most PFT labs are going to use. They're going to say that if you don't get your patient to keep pushing for at least 6 seconds, your results may not be that accurate that you get from there. So I'm going to say that. We strive for, I don't want to use that. I'm so sorry. My brain is just fried right now. I'm so tired. I can't even like put my words together here. We should do this for a minimum of 6 seconds. So it's kind of like a quality control or quality assurance kind of thing. And they also will get them to do this 3 times, and the machine will be able to show you which one is the best out of the 3 efforts. So out of the 3 efforts, they have to be close to each other. So you can't have one that will say like vital capacity was 4 liters the first time. The next time it was 8.5 liters. And then the next time it was like 5. So those are nowhere close to each other. So they should be pretty reproducible. Meaning they should be pretty close. And then you're just looking at the best effort out of those 3. The FEV1 FBC ratio, sometimes this is just written as FEV1% because this is technically a percentage that we're looking at. We're looking at how much of your vital capacity you got out in the first second. And we just say that as the FEV1%. All right, now when we look at our numbers that we get from the test, this ratio is going to guide us, and it's going to show us for sure when there's an obstructive problem. Because if there is not an obstructive problem, if there's no issues with getting the air out, then this ratio will be definitely greater than 70%. So FEV1% or FEV1 over FVC greater than 70. No, let me do this less than 70% confirms and obstruction. And when we say obstructive, in this sense, we're talking about small airways. We're not talking about like an upper airway obstruction. While that could still be true, we mostly are thinking about the lower airways. I think asthma. All right, so the FEF 25-75% forced expiratory flow. And 25 to 75 does represent about the middle of your body capacity. So as you get into blow, 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 up until like the first 0 to 24% that's coming out, that is reflecting what's going on in the upper airways. And then when you get to about the 25 to 75%, then that would be more along the lines of the middle airways. And that's all that we're really concerned about with this FEF 25-75% is what's happening in the middle airways, or really the small airways, if we want to just make it even more simpler. So I'm going to write here, this focus is more on the small airways. So if this number was abnormal, then you're thinking about definitely there's a problem with those small airways. Okay. Now the forced expiratory flow, or FEF 200-1200, the 200 and 1200 is of course relating to milliliters of air. So once again, it's all coming from the vital capacity. Blow, 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 keep blowing, keep blowing, keep blowing, keep pushing. It's not a separate measurement at all. In other words, once you get the vital capacity, the PFT machine will just start to slice it up into these different little measurements here and give you like the FEF 25%, 75%, the FEF 200-1200, the PFR, the FEV1, and et cetera, et cetera. So now back to the FEF 200-1200, where we're ignoring the first 199 milliliters of that air, because that is all definitely upper airway. That's like your trachea. That's pretty much like your trachea. Like and then from 200 milliliters to about 1.2 liters or 200 milliliters, that would be more along the lines of your large airway. So then this right here, the focus on this one is going to be your large airways. Now, if you have a problem with your upper airways or your large airways, this number is going to be abnormal. And then the PEFR, or peak expiratory flow rate, that's just that. We've been talking about peak flow for a while now. We've been talking about setting your peak flow on the ventilator if you're in a mode that allows you to set it. This is pretty much kind of the same thing. It's just looking at the instant, the first instant when you are blowing the air back out. So you take in the deepest breath that you can take in, and then when you blast it out as hard as you can, literally the first second, even less than that, that's going to be the fastest that the air is going to be moving out of your airways. So that's why it's considered to be the peak flow or peak expiratory flow rate. And then as the lung starts to empty out more, things slow down. No different from that tire. The tire that you poke a hole in the tire. At first, the air is going to come out really fast, and then it starts to slow down as the tire deflates more. So there's a problem with your peak expiratory flow rate, and abnormally low can be related to small or the large airways, really. When you think about the resistance to airflow, if there's something that's preventing the air from leaving very easily, it's going to create a lot of resistance. And if there's a lot of resistance, then the air is not going to be moving that fast. So that's why your peak flow rate, or PEFR, will kind of give you a pretty good idea of what's going on. And these numbers will usually support each other, meaning that if your, say, FEF 25, 75% is really low, which is, again, your small airways, if that number is really low, then it would make sense that the PEFR is going to be low as well. Because how can your PEFR be normal if the small airways are maybe constricting? So it's just not possible. So that's why we look at all these numbers and make sure they all kind of point toward the same issue. It would not make any sense whatsoever to have a normal or even above normal peak flow rate when your FEF 25, 75% is really low, or your FEF 200, 1200 is really low. All right, and then one more thing. Your going back to the top of the page here, the first second, the FEV1, it would not make sense that that would be normal if, once again, your FEF 25, 75% is really low. Because how could it be that you got out the expected amount of air in the first second when there's something that's causing your airways to be more narrow than they're supposed to be? So these test results give you a chance to find out what the problem is in many different areas. So if you don't focus on just one, you look at all of them together, then they'll all kind of like say, this is the issue that's going on. Now, diffusing capacity, the DILCO or DLCO, this is all about those situations where you have someone who's got some kind of thickening going on in their alveolar capillary layer. the AC membrane is now thicker, which means that there's diffusion. The O2 is now diffusion limited, and they're short of breath because of that. So anybody could have a diffusion problem. So when it comes to our lung diseases, we're starting this topic with obstructive diseases. It's true that obstructive diseases will cause dyspnea and increased shortness of breath. But what about the restrictive diseases? They'll cause the same kind of problems. They'll cause the shortness of breath and the dyspnea. And then what about the fusion problems? They're going to be short of breath because of the fact that the O2 is now having a hard time diffusing across the membrane into the capillary blood. So really, this PFT test is going to help the provider get to the bottom of what's going on. Because Ms. Smith is sitting in front of you right now, and she's complaining about how short of breath she is. And she's saying that every time that she gets up and tries to walk around, she gets even more short of breath. So then you can't automatically say, well, Ms. Smith, you might have an obstructive lung problem. And you can't automatically say, well, you probably have a restrictive lung problem. And you can't automatically say, your problem might just be only that you have a diffusion problem. That's it. Looking at all these, again, values together, they're going to usually help you to figure out exactly what's going on. So we use carbon monoxide with that test. It's not a lot. It's just they'll take in like a single breath. If you're the PFT, if you're the PFT technician, you're going to, at that stage of the test, you're going to have the patient take in a deep breath of this gas mixture. And it'll be a little bit of carbon monoxide, some oxygen. And I think they had a little bit of helium with it as well. So then they'll say, okay, take in a deep breath and hold it. Then they'll hold it for whatever the maximum amount of time is that they'll get you to hold the breath. And then they'll have you just exhale back through the mouthpiece. So you don't take the mouthpiece out. You just keep it in your mouth, take in a deep breath, hold it, and then exhale back through the mouthpiece. What the analyzer is looking for, or the machine is looking for, is how much carbon monoxide came back in that breath when they exhaled it back out. If there's a diffusion problem, a lot more came back than should have. If there wasn't a diffusion problem, the machine should not be able to detect any carbon monoxide at all, or if anything, very, very, very low, because we know that carbon monoxide compared to O2, hemoglobin much rather prefer binding with carbon monoxide than hemoglobin. So there's no problem. There's nothing holding the gas back. It'll quickly, once you take the deep breath and hold it, it'll quickly diffuse over into the blood and connect with the hemoglobins. Now, the ATS, the American Thoracic Society, this is what most of your PFT labs, I mean, they're having to they're having to comply with the standards that are written here. And that has to do with quality control. If you have a PFT lab that does a lot of these tests on a regular basis, on a daily basis, you will have to, first of all, every lab has to start off with calibrating all their equipment in the beginning of the day before they start even seeing any patients. And your calibration has to be tight, meaning that your numbers that you get should be really, really, really close. Really close. Let me get, there we go. Let's see, calibration. Uses a 3-liter, we call it a super syringe. And maybe you had a chance to see one of these. I think we had one in the lab, and it disappeared. So I'm thinking it's probably in Eden's room somewhere. He probably had it showing it to you guys when you were doing this in term 4. So it uses a 3-liter super syringe. And then ATS expects plus or minus 3% or 50 milliliters. Now, what that means is that the machine is going to guide you. It's going to tell you, almost like when you do SST on the ventilator, the machine will guide you through the steps that it wants you to do. With the calibration, your super syringe is going to be 3 liters always. Always. That's what it's designed to hold. It's designed to hold 3 liters of air. And it's like a big plunger is what it is. So then the machine will tell you, okay, pull back on plunger and then slowly push plunger in or something of that along that lines. Sometimes it's going to want you to push it in very slowly, and other times it'll tell you to do a little bit faster. But either way, you've got to be, your machine has to be able to measure within about 3% under or 3% lower than the 3 liters. So what's 3% of 3 liters? That's not a lot of room, as you see. It's got to be really, really close. So if your machine is measuring more than 3%, whether it's higher than 3 liters or lower than 3 liters by more than 3%, then you got to redo the test. You got to keep redoing it and keep redoing it until you get a number that falls within that very narrow, like 3% margin. That's one of the requirements. I mean, they got there's other standards in there as well, but that's one of the main things is that your machine has to be able to pass calibration. If you got a busy lab, you've got to do this calibration multiple times throughout the day. You can't just do it in the morning and continue to do all these patients and expect everything to still be okay. You want to be assured that the numbers that you're getting in your test results are pretty close and they're pretty accurate. And that's the whole point of calibration. It's all a quality assurance kind of thing. And then number 9, the gold, the gold standard. GOLD just stands for, as you see, Global Initiative of Obstructive Lung Disease. And this is something that is applied to any COPD patient. These COPD patients, and we'll talk about COPD at the very end of this presentation, but these patients they're going to be short of breath, as we know, but when we give bronchodilator to someone with COPD, they don't really get the full reversibility that say like an asthmatic would get. And even though it won't really help as much, it still helps a little bit. And in some cases, it helps a little bit more. But the gold standard is always going to say that regardless, you're still going to prescribe these bronchodilators to someone with COPD, even though COPD by definition really does not fully reverse. Like the bronchospasms that they're experiencing, they just don't reverse with the medication completely or enough. And then on your report, it may show LLN, and LLN just means lower limit of normal. Everyone's going to have their own normals. That's why I didn't want to even like label that spirogram, like with the normal, what should a normal tidal volume be? What should a normal IRV be? What should a normal ERV be? At some point you did have to memorize that, but I didn't want to bring that back in because I wanted to jump right into the LLNs, like, you know, for someone who is a male who's this tall versus this is a female who's this tall. What should their what should their normals be? And the computer will figure it out. And then from there, once they do the test, now you got something to compare it with. This is what they should have been doing, but this is what they did instead. And that leads us to the percent of predicted, which is number 11 here. So this is an easy calculation. So if the computer will again ask these questions: what sex is the patient? What race? Because most ethnic races, they're going to have slightly lower volumes and capacities compared to, say, like Caucasian. And the computer needs to know this so they can make the adjustment. And then it'll ask for, like, how tall, because as I've said before, the whole point of doing like ideal body weight calculations when we're doing things like ventilator settings and even drug therapy is no matter how many pounds you weigh, your lungs are only going to be as tall as how tall you are. So if you're overweight, if you're grossly overweight, but you're really short, your lungs are still short. And if you've got someone who's really, really, really tall, so think like NBA, you've got really, really tall lungs and a lot more capacity compared to someone who was shorter. Now, percent predicted is just you're measured. Sometimes people will call this the actual results, like this is what the patient really did when they, when they did the test. I'll just write what you measured divided by the predicted, what they should have done, and then that times 100. So it's a very easy calculation. It's just if you should have done 50 milliliters, but instead you did 25, then we know that's 50% of predicted. You did half of what you were supposed to have been doing. Okay, so now here's some examples that we have, at least as far as the different kind of patterns that you expect to see. Wow, it's lunchtime. Feels like we're not getting anywhere today. So we'll be back at 12:30.